Hello.
I am.
I'm very happy to be with you here. The first presentation was good. The second one was good, and last but not least, the third one will be very good because you're going to talk about troubleshooting, and which is a very interesting part. So I will like to give you the word, and I will listen carefully. Okay.
Okay. Thank you. I have no disclosures with referral to this topic. Let's start from the basics of hemodynamic monitoring. ECG is something completely non-invasive. It is just the tracing of the electrical activity of the heart over the time. Conventionally, we use the standard IC monitoring few electrodes, usually 3 or 5. Few electrodes means few leads, and few leads mean few data. It is not the standard 12 leads ECG. This is what you're going to see on your monitor. You're going to see the tracing and the number, which is the heart rate. Place the electrodes carefully in order to have clear, reliable tracing. Moving the electrodes over the chest modifies the point of view, so modify tracing. Check the position first before alerts about ECG alteration. This is a common artifact, usually due to wrong position or wrong gain, with monitor reading large T waves or small QRS at the same time, doubling the heart rate. Check another trace as pulse oximetry and reposition the electrodes to get proper tracing. You could also have other kind of artifacts with ECG, and these artifacts could impair ECG interpretation. You could have motion artifacts due to movement, deep breaths, coughing, electromagnetic interference, for example, for electrocautery, muscular activity, tremors, shivering, stiffness, or seizures. You could see everything from just a simple wandering baseline to rapid spikes which could completely cover ECG tracing. This kind of artifact, it could be immediately evident as an artifact, but sometimes artifacts could mimic specific arrhythmias, and obviously you're not going to have any hemodynamic impairment, so again, check other monitoring tools before reacting. Look at this. It is an asystole. If no cardiac electrical activity, no contraction, no output, so no blood pressure, no pulse oximetry. Check the electrodes, because if you have a blood pressure, if you have a pulse, it is not an asystole. So maybe it is just one or more electrodes that are getting displaced. But be aware, it could be a real asystole. So be ready to start with your CPR as needed. Another kind of arrhythmia that you need to recognize immediately in the ICU is ventricular fibrillation. It is a chaotic ventricular activity with no pulse, no consciousness. If patient who was awake is not going to answer anymore, this is a cardiac arrest. It could be coarse ventricular fibrillation. It could be fine. Does this matter for you? No. Call for help and start CPR and provide a shock as soon as you can. Another arrhythmia which could induce a cardiac arrest is the ventricular tachycardia. Can be monomorphic, like the first one here. You have the same morphology, the same shape for QRS, or polymorphic, like the second one, with different morphology for QRS. What you need to do immediately is to understand if you have a pulse or not. Check the arterial line tracing, then physically check central pulse too. If pulse, let's go for CPR and shock. If you have a pulse, consider that probably the patient will be unstable, as ventricular tachycardia easily impairs cardiac output due to the extreme heart rate. You have 200, 250 of heart rate with hypotension and cardiac failure. The decreasing cardiac output may also result in decreased myocardial perfusion with evolution to VFib. You still need the immediate help and take the defibrillator nearby, as probably the patient will need a shock or cardioversion soon. This is a specific form of polymorphic ventricular tachycardia. Its name is torsade de pointe, TDP. The QRS twists around the baseline, around the isoelectric line. Heart rate is again fast, 200, 250. This is short-lasting because TDP can easily convert to ventricular fibrillation. Be careful. It is usually associated with QT interval prolongation, And we have seen a lot of drug-induced QT prolongation in COVID-19 patients, as these patients received a lot of medication at the same time, antivirals, antibiotics, antimalarials, all potentially prolonging QT. It is also associated with electrolyte imbalances as hypokalemia, and is often approached with magnesium administration as a first-line approach. Be careful to consider to administer potassium without any clear evidence of low potassium. If the patient is unstable, again, you maybe are going to need a shock to require to avoid any worsening of the situation. So, a lot of this situation require CPR and shock. Become immediately confident with the defibrillator you're going to have in your ICU. It could be easy in the ICU not to have automatic defibrillators, but manual ones. Don't be scared. You could learn how to use this device with a really basic training to be done before any cardiac arrest eventually occurs. Arrhythmias and cardiac arrest in the adult patient may be related to coronary artery disease. It is hard to diagnose ischemia based on a single trace on an ICU monitor. You could have artifacts due to electrode displacement. Maybe patient is not awake, so you lost a symptom. If you have any doubt, ask for help. If something is going on, someone needs to plan the additional steps to eventually provide reperfusion fast. In the meantime, go for a 12-lead ECG, as it is the first thing anyone is going to ask you. You could also have less risky arrhythmias in the ICU. Probably the most common sustained one you will see is atrial fibrillation with a disorganized atrial electrical activity and loss of P waves, the loss of atrial contraction. Main complication of AFib is the hemodynamic instability, particularly if the rapid ventricular response. You need to know AFib because it's really easy to recognize atrial fibrillation. And if you have a recent onset, this should be approached immediately with electrical or pharmacological cardioversion to avoid any adverse event or hypotension. Any doubt on the presence of P wave, go for a 12-lead ECG again to get the whole picture. In the ICU, it's also common to have a sinus tachycardia. It's easy, it could be fever, stress, pain, dyspnea, impaired gas exchange. And all of these are common in COVID-19 patients. Should be also opioid withdrawal during the weaning phase. Treat the cause, not the ECG to solve the arrhythmia. P waves may not always be visible if the tachyarrhythmia is really fast, but consider that above 150 of heart rate in the adult patient, it's unlikely a physiological response. We also have bradycardia. Do the patient need treatments? No, if the hemodynamic is stable. So no drugs, no pacemaker, no pacing. About pacing, consider that you have the possibility, if the patient have a pacemaker, an ICD, or a CRT, to see the tracing, the spikes of the device on your ECG tracing on the monitor. And this is important because you need to understand, you need to know if the patient has one of these devices. Check under the skin, check chest X-ray to have additional details, as the activity of this device may arise or simulate some arrhythmias. Some of the devices may also provide therapies against arrhythmias, but maybe you just need to consult your electrophysiologist because you need to understand what kind of device the patient have, and you need to understand if reprogrammation is needed. Let's move to pressure monitoring with basic pressure, blood pressure, systemic blood pressure, and central venous pressure. Is a transducer. The transducer is the system which converts the mechanical signal, which for the purpose of this talk is blood pressure from the patient vessels, to a digital signal. You are going to read both a waveform and numerical values. With the disposable transducer, which are the ones you are going to find in any ICU, you need to perform some actions before considering the readings as really reliable. The first thing you need to do is name zeroing the transducer, as you have seen in the previous presentation. You just need to remove the cap from your transducer here, and you just need to turn the stopcock down towards the patient so that the only pressure the transducer is now exposed to is the atmospheric pressure. We are adjusting to the system to consider the atmospheric pressure to which both the monitoring system and the patient are exposed as the starting point, so as the 0 point for the reading. This is what you are going to see on the monitor during the 0. You need to repeat this procedure for every monitoring system or any pressure monitoring system you have on the patient. And you need to do the 0 when you start the monitoring at first, anytime you disconnect the system for any reason, and anytime you have any doubt about the waveform or about the values you are reading on the monitor, just check. It requires really few seconds. After the 0, you need to flash the device, pulling the fast flash or snap tab, which is this one here, on the transducer. A square wave will appear on the monitor as the pressure will be over the range of reading. If you stop flashing, you need to see about 1.5 to 2 swings before the waveform appears again. This is what we call optimal damping of the system. The second thing you need to do is placing the transducer at the proper level. The choice of the reference level is critical. This reference value is an arbitrary decision, but the commonly accepted point of reference for most of patients for hemodynamic monitoring in the ICU is the midpoint of the right atrium. For this is where the heart interacts with the returning blood, and so it's okay. This kind of tool, it's okay for intravenous pressure, and the right atrium is more or less at the same level of the aortic root and of pulmonary artery roots. So it's okay also for blood pressure monitoring and for pulmonary pressure monitoring. But how can we find the right atrium on the patient at the bedside? There are a couple of methods. One is the phlebostatic axis level, which has been previously proposed. There is another one which consider the midpoint of the right atrium on average at a vertical distance of 5 centimeters under the sternal angle or angle of Lewis, which is where the second ribs meet the sternum. This is true whether the patient is supine or sitting up to a 60-degree angle. This means that the patient does not need to be supine for these measurements if you use this reference level. And ICU patients to date are mostly in sitting or semi-sitting position, particularly severe respiratory failure patients. More commonly, as previously said, the mid-thoracic position at the level of fifth rib is used, the phlebostatic axis. This is easier to teach, but should be used only for measuring pressure in the supine position. Leveling is so important. Not being rigorous in proper leveling introduced error. For each centimeter of offset, you have 1.36 millimeters of error. If the transducer is too high, pressure is underestimated. If the transducer is too low, pressure is overestimated. And these mostly impact the low values as CVP or severe hypotension. Check and fix the level every time you move the patient, every time you move the bed, and every time you have any kind of doubt. So now you are supposed to have a reliable value with a clean waveform, but there is another thing you could do to optimize the waveform, which is fixing the range of reading on the monitor to improve the visibility of wave components. If the range is too low, you are going to lose the peaks of wave. If the range is too high, the wave is going to appear attenuated. You need to adapt the range of the pressure to the pressure of the patient, of this particular patient, and in this particular moment, and you need to modify the range as and when needed. Be ready. Sometimes, despite having a proper range, wave appears attenuated, more and more static, with usually an increase in mean arterial pressure and a decrease in pulse pressure. The technical definition is overdampened wave. What is going on? You need to consider that for the system to be effective, it requires to be completely fluid-filled from the patient to the transducer. No microbubbles, no macrobubbles, no clots, no kinking. Check the wall line, as any of these is going to impair or prevent pressure readings. Moreover, try not to modify the system, as the system is not compliant, meaning that the walls of the lines do not absorb the pressure, and it is recalibrated to be at a fixed length. Removing or adding or replacing any component impair its integrity and its reliability. So please avoid any manipulation of the system. Be aware you could have kinking also at the catheter level, particularly if patient is awake and with radial arteries. Another potential issue is a clot that could be on the tip of the catheter. You are going to be able to flush the catheter, but if you try to aspirate blood, this is not feasible. Why? Because when you flush, you displace the clot. When you try to apply suction to suction the blood, the pressure is going to call the clot back, and the clot is going to occlude your catheter. And this catheter is going to will need to be replaced soon. So now let's move to a couple of pressure monitoring, CVP and BP, to understand what could happen and what is the significance of this kind of monitoring. Let's start from CVP. This is a normal CVP reading with the waveform and with the numerical value. The most common artifact, the most common alteration in patients with respiratory failure is due to tricuspid valve regurgitation, with the backflow from the blood from the right ventricle making the wave appearing as ventricular. Consider that this wave could also be due to a too deep insertion of central venous slide. So let's check what kind of the problem you have in your patient with a chest X-ray or with echo. Another common artifact is a really high reading with no visible wave, as the pressure you're reading is completely out of the range. It's mainly due to drugs and fluid administration, which could impair pressure reading. So consider to stop this kind of administration when you need to read a proper value of central venous pressure. So I think the main issue about central venous pressure is lack of understanding of what CVP is and what CVP is not. Can an isolated value of venous pressure be considered as a surrogate of intravascular volume? No. CVP could be useless to assess volemia or to assess venous return. There are so many factors impacting on CVP: mechanical ventilation, intrathoracic pressure, intra-abdominal pressure, also patient position. You need to know all these factors to properly understand the significance or the lack of significance of the value you're reading before using this value to eventually guide treatments. What if you have a low CVP? It could be hypovolemia, or it could be venodilation, which is hypovolemia relative to increased venous capacity. It might be difficult to distinguish about between absolute hypovolemia and venodilation. Could be also both problem at the same time. Normal CVP per se does not necessarily reflect normovolemia, as the body can mobilize or pull blood from or in the compliance blanketing vessels. So a normal CVP could be a compensated hypovolemia or compensated overload. Combination of factors that may decrease or increase CVP may also lead to a normal value despite main hemodynamic derangements. And then we have main issue. The main factors causing an increase in CVP include a decrease in cardiac function. Often COVID-19 patients have decreased right ventricular function and tricuspid regurgitation. Sometimes they have a global myocardial dysfunction too. Also, an increase in pulmonary vascular resistance may be secondary to hypoxemia, which is really common in this population, is able to increase CVP. High mechanical ventilation settings and an increase in intrathoracic pressure raise CVP. An increase in intra-abdominal pressure may increase CVP due to the shift of blood from the splanchnic bed and due to the shifting of the diaphragm up. So it is really hard to say what is going on without any additional data. We often see raised CVP in this kind of patient, and it tells you nothing, because it could be all of this. It could be nothing. It could be also the patient could be also hypovolemic but have a raised CVP. So be careful. Let's move to blood pressure. Invasive blood pressure or arterial blood pressure, meaning systemic blood pressure. Maybe it's a bit easier than CVP, maybe. You have a typical waveform, it's a pulsatile pressure with 3 values: systolic, diastolic, and mean arterial pressure. You could also take a look at the trend with most monitors, and this could be really useful in some patients. Again, with blood pressure, you need to understand what blood pressure is and what it is not. You could have hypotension because of impaired cardiac function, or because of low resistances, or both, or maybe it's a volume issue or a combination of factors. Again, you need to integrate different data. What's your target mean arterial pressure? It really depends on the patient in that particular moment. Different conditions require really different targets, maybe to double or more. You could suppose that keeping a certain pressure would provide a proper perfusion, but blood pressure alone is not giving any information on cardiac output or on oxygen delivery. Is the hemodynamic status of your patient impairing an organ and peripheral perfusion, or is the patient at imminent risk of hypoperfusion? It is time to take a look at the patient. An easy mistake when you enter the ICU and start caring for this cohort is just relying on the monitor, forgetting the patient. Our resuscitation targets are macro hemodynamic parameters. We have seen heart rate, mean arterial pressure, central venous pressure, but when blood pressure significantly drops, the associated sympathetic response is vasoconstriction, which results in a decrease of blood flow. And peripheral tissue are the first to suffer from impaired perfusion. The traditional markers of tissue perfusion may be not so readily available in the ICU patient. Lactates take time, and it is not continuous monitoring. Urine output could be a good marker of renal perfusion, but with delayed response to treatments and continuous assessment of urinary flow, at the moment it's not visible. And urinary output is unreliable in acute kidney injuries or chronic renal failure. Titrating the fluids based to urinary output alone may result in fluid overload. So we need something else. And the skin is visible and easily accessible organ, allowing the simple observation of peripheral tissue perfusion through temperature alteration, perfusion alteration, and color alteration. An easy first step is the physical examination of the temperature of distal extremities. Non-invasive and inexpensive, can be repeated often without any risk to the patient. It's nothing new. The finding of cool extremities may represent a compensatory mechanism of shock physiology resulting from a reduction of peripheral perfusion in the attempt to preserve central perfusion. Skin temperature gradients may be more accurate in the evaluation of critical ills, particularly gradients between peripheral and ambient temperatures, central and peripheral body temperature, and finger and forearm skin temperature. Also, patients may also have cool extremities because of target temperature management, exposure to a cold environment, peripheral vascular disease, or warm skin could be the results of vasodilatory shock, such as spinal shock or warm septic shock. Again, you need to integrate different data and different monitoring tools. Another easy test, capillary refill time or capillary refilling testing. It's a simple, easy to learn, can be used in almost any setting at the bedside for assessing peripheral circulatory status. CRT is determined by applying a blanching pressure on a soft tissue, generally the fingertip, generally the index, but could also be the knee. And you need to measure the amount of time necessary for the skin to return at the baseline color. Normal is 1 to 2 seconds, above 3 seconds is normal. It is one of the dynamic parameters with skin temperature to assess fluid responsiveness in patients with COVID-19 shock, which has been suggested by the SICM and SCCM Surviving Sepsis campaign guidelines. Used as a qualitative variable, prolonged or not, CRT is a reliable tool to identify critical ills at risk of negative outcome. Could be unreliable if severe peripheral artery disease and hypo or hyperthermia. Another easy clinical sign to be assessed is mottling. Mottling is defined as a patchy skin discoloration, usually starting around the knees due to small vessel vasoconstriction and reduced skin blood flow. Can extend to other peripheral circulation as the fingers or hair. A semi-quantitative clinical mottling score has also been proposed and validated to guide treatments targeting organ perfusion and microcirculation. This score is based on the extension of the purple patches on the legs, ranging from 0, no mottling, to 5, extremely severe mottling area that goes beyond the fold of the groin. Mottling could reflect splanchnic hypoperfusion, including kidney hypoperfusion, and reliably reflects organ failure severity in patients with sepsis and septic shock. And mottling is a predictor of that in this population. If you have a score ranging from 0 to 3, doing a capillary refill test of the knee could improve risk stratification. All these tests have been are reliable. Some of these are also validated. The main issue for mottling and capillary refill time is that you could have some problem with patient with darker skin color. So now we have a lot of data on macrohemodynamic and microcirculation. What we could do with these monitoring tools? Because we use this data to guide treatments, to guide therapy. Fluid loading is usually the first step in the resuscitation of patients with acute circulatory failure. Fluid responsiveness is the ability of the heart, mainly of the left ventricle, to increase its stroke volume in response to fluid administration. The aim of increasing stroke volume is increasing cardiac output and oxygen delivery. Giving fluid is not beneficial if cardiac output is not going to increase. Moreover, fluid overload could harm the patient. A simple test you could do at the bedside at any time to understand if the patient is potentially fluid responder is the passive leg raising. The principle of passive leg raising is that the volume of blood from the lower extremities and mesenteric splanchnic pool, on average around 300 milliliters, is auto-transfused to the central circulation. No fluids, it's actually administered to the patient, so it can be considered a reversible or virtual fluid challenge. Easy, not so much. Some rules need to be taken into account when performing a passive leg raising. First, you need to start from the semi-recumbent, non-supine position. Then you need to understand that the technique you use to assess the effect of passive leg raising must be able to detect short-term transit changes, as passive leg raising effects may vanish in 30 to 90 seconds. The accuracy of passive leg raising is better when hemodynamic effects are assessed by a direct measurement of cardiac output, and problem is that probably you are not going to have cardiac output monitoring in standard ICU patients. So use what you have, and tidal carbon dioxide or blood pressure. The basic assessment must be evaluated not only during and after the test, before and during the test, but also after the test to understand if everything is going to return to the baseline. Consider that pain, cough, discomfort, awakening of the patient could provoke adrenergic simulation and false results of the test. So do not touch the patient during this assessment. And another important rule is that you need to consider that a lot of confounding factors or underlying conditions may influence the passive leg raising, and you need condition before performing the test. For example, raised intrathoracic pressure, intrathoracic compartment syndrome, like a tension pneumothorax, cardiac tamponade, right ventricular failure of any etiology, or abdominal hypertension. All of these could impair the effects of passive leg raising. So patient probably is not going to respond to the test. So maybe the patient does not need fluids. Maybe the patient is potentially fluid responders, but again, maybe he does not really need fluids. Maybe he does need something else. He needs vasopressor, he needs inotropes. he could not understand with this basic monitoring if the patient needs this kind of drug and which kind of drugs the patient actually needs. So maybe you just need some additional data, non-invasive data or invasive data, or maybe you just need additional help to perform these other kind of monitoring and to understand the impact of this kind of monitoring and to understand the results of this kind of monitoring, because what you have at the bedside could be at the moment not enough for the patient you have. So basic macromodynamic data could be enough for most of the patients, but sometimes you need something else. And that's all.
Okay, thank you very much for sharing your knowledge, Vilja. It was a very nice illustrated presentation, very nice one. But I'm still a little bit confused. I remember when I started as a nurse in the ICU, that the ECG was a very big problem for me. And there was one doctor who told me that if you don't recognize the ECG waveform, there's only one thing to do, that's check your pulse or search for an IBP line on the monitor. Then you are sure that there's still some cardiac function. And you explained several types of arrhythmias, but we can use the waveform on the monitor to make sure that if it's really something life-threatening or not, I suppose.
Absolutely.
Yeah.
As I previously said, if you have a pulse, probably the patient is not going to need CPR. So check all the monitoring tools you have at the bedside. Just do not use just single things, and look at the patient. Look at the patient.
Yeah. If he's awake and he has no forms, then something is wrong. Indeed. So I understand it's really our job as a nurse to check and maintain the correct leveling. And I think it's very important to alert the physician when you see that the numbers are changing on when you're really in doubt. Probably something appears on the monitor and it disappears again, but it might be a precursor for something that is coming. So it's a pre-alert. So I think it's very interesting that you explained most of the things. But what is the most comprehensive and reliable tool to monitor the hemodynamic patient, critical patient?
I think that today, in 2020, we have a tool to monitor ICU patient, which is non-invasive. Is something which allows us to open an immediate window on the patient, a non-invasive window in few minutes. We could take the probe of our ultrasonography machine, and we could take a look at the patient. We could take a look at the heart, is moving or not, and how do we have any issue with the right or left ventricle or both. We could understand if the patient needs inotropes rather than vasopressor in few seconds. We could understand if we have a potential sign of raised pulmonary pressure. We could check for sign of venous excess of general overload, so or for findings suggesting hypovolemia, to understand if the patient needs fluids or not, if the fluids are going to be beneficial or harmful. All of this in few minutes with few basic competencies. It is not a full cardiac or vascular ultrasound exam with complex assessment. It is just something like taking a look to understand what is going on at any time, before treatments, during treatment, and after the treatments, to understand the effects. Obviously, it is not continuous, and we also need continuous monitoring tools. Sometimes we need advanced continuous hemodynamic monitoring. Maybe we need cardiac output, maybe we need a mixed venous saturation in some selected patients, but most of our patients will just require a basic exam, something really basic. And I think that we require at the moment in the ICU this kind of competencies. And it's really important for provider, both physician and allied healthcare professional, to acquire this kind of competencies to properly care for the patient in the ICU. But for basic care at the bedside every day and for emergency situation. It saves lives.
Okay, it saves. That's the most important thing. Thank you very much.